Well, hello everyone, and welcome back to the next lesson on our ECG interpretation. And as you might guess, we are going to be doing the EKG signs of acute ischemia. So in this lesson, we are really going to talk about the classic changes that we see in ischemia. There are some really specific cases that we're going to deal with when we talk about the ECGs we have to own. But this is just a refresher on some of the classic findings. And then we're going to talk about localization. So how do we use the ECG to actually localize these ischemic findings on the heart? So really, the classic findings of ischemia on the ECG fall into three broad categories. The first of which are your acute T wave changes. And these are really your hyperacute T waves and your T wave inversions. Following that, if your ischemia gets worse, you start to get some ST depression and, of course, the ever famous ST elevation MI. So that's kind of your gradation of ischemia that we're going to find on the ECG. So just take a moment and have a peek at this ECG. And in particular, I think your eyes are going to get drawn to the T waves, particularly V2, V3, V4. These are really what we call the hyperacute T waves we see in ischemia. They're big, and for sure when I see T waves that are larger than the QRS complex, I'm certainly going to be wondering what's going on. And in the right patient population, this would be worrisome for ischemia. So this is the chest pain patient or the patient with diabetes and shortness of breath and reasons where they may not have a chest pain but a chest pain equivalent. Of course, every time you see big, tall, peak T waves, we do have to think about hyperkalemia, and it would not be a wrong thing to be on your differential diagnosis, although these are sort of a little more broad and wide than the really tall peaked T waves that look like they're kind of pulled up from the tip of their T wave. They can be a little tricky to differentiate, but anyways, this would be a hyperacute T wave. So let's say this is a 56-year-old patient with chest pain, and take a moment, maybe pause the video and have a look at this ECG. Actually, I guess the answer to the thing is right on the top of the slide. So your eyes are going to get drawn particularly to the lateral leads in V4, V5, V6, and maybe a little bit in 1 in AVL, where you see ST depression. So in this case, you're going to see a very flat ST segment that's depressed more than 0.5 millivolts below the baseline. And the baseline, I think most of us know this, but the baseline we're going to take is the TP segment. So that line between the T wave and the P wave of the complex we're looking at is going to be our baseline. So if you have sort of more than a half a box of ST depression below that, you're thinking significant ST depression, and that's certainly what we're going to see here in this case. One thing that I found interesting about ST depression, and something I guess I didn't know in the past, although interestingly enough, it's probably just something I never learned, is that ST depression actually does not localize. So when I say that, when we think about ST elevation MIs, we can often figure out what area it's occurring in, whether it's lateral, whether it's posterior, whether it's inferior, just by looking at where on the ECG those changes are. And funny enough, I guess I had never run across this, but it turns out that ST depression doesn't localize. So when you get people on treadmills and they show ST depression, basically what you find does not localize to what you find on the cath lab, and the same thing for what we see in the emergency department. So if you see ST depression, that would be something that, yes, is worrisome for ischemia, but you probably can't predict where in the heart that culprit lesion is. Now this is ST elevation, but while we're sort of thinking ST depression, the only caveat to not being able to localize things is the ST depression that we see with reciprocal changes. So in this case, if you have a peek at the ECG, your eye is going to go very rapidly to the ST elevation, right? In V2, V3, V4, V5, V6, 1 in AVL. So this is a pretty large anterior and anterolateral MI. And then you're going to get ST depression, and you can certainly see it in 3 in AVF here, which is the reciprocal changes. So if you see ST depression that looks like that it is anatomic, then you should be looking in those reciprocal leads for an ST elevation MI. And anyways, the ST elevation that you see here is sort of the classic upwards sloping, downward sloping ST changes that look worrisome for an MI for sure. And so I think, these sort of ECG changes are probably pretty much a review for most of us. But sometimes the localization is a little tricky. And I really highly recommend you poach this picture, put it on your iPhone or device. The link for it is at the top. It's in Life of the Fast Lane, which basically allows us to use all their images for free, which is great. And I actually have stuck this one on my phone, partly because you can do access with it, you can do ECG localization with it, and at 4 in the morning, if your brain isn't working awesome, that's great. It's also a great teaching tool to use if you're teaching learners a little bit about localization, a bit about access and the like. Now, one of the things, if you joined us through the earlier parts of these lessons and had gone through all our ECG leads teaching, is one of the ways to remember which ECG leads go where is that if you take a lead and you take the positive electrode of the lead, where that sits is basically the end of the heart that it looks at. So if you really look at, say, lead 1 or AVL, this is on the left side of the chest. AVL, of course, going towards the left arm, lead 1 going straight right to left. And of course, that's the lateral aspect of the heart. Similarly, if you remember leads 2 and leads 3, these are the ones that basically the positive aspect is at the groin, because the groin is always positive. Well, that's the inferior aspect of the heart. And so those are a couple of the leads that are going to look inferiorly. Same with AVF, which of course is basically pointed straight down if you've been through our leads lecture there. So if you know your leads, it's actually kind of easy to remember where things are. Having said that, most people just sort of memorize them. So, having a peek at this one, why don't you take a moment, pause the video with either your spacebar or the pause button, and we'll come back to what this is in a second. So for those who have had a peek at it then, I think you're going to see the ST elevation, certainly V2, V3, V4, a little bit in V5, and I think you convince yourself there might be a hint in 1. And then you've got reciprocal ST depression, particularly evident in 3 and AVF, although a bit in 2. So really, we're looking at an anteroseptal MI. And if you have a peek at our diagram here, that really actually makes a lot of sense, right? So really, V4, V5, and V3 were really fairly obvious, and they really cover that sort of anterior and anteroseptal area on the front planes of your ECG lead. You may see some stuff as it gets laterally 1 and AVL. And of course, reciprocal, meaning it's at the other end of the heart, would be your inferior leads. So your 2, 3 AVF, so you're expecting to see your ST depression. So that would be anteroseptal with a little bit of lateral on it. So take a moment, maybe hit the space bar, pause for a second, and have a look at this one. So having a peek here, I think you'd be pretty obvious. You're looking certainly at leads 1 and AVL for some big ST elevation. You may convince yourself also that particularly in lead V5 is some ST elevation there. So you're looking at a lateral MI, and then you're going to see the reciprocal changes, particularly 2, 3 AVF. And so if you have a look there, your lateral leads, of course, on this diagram are leads 1 and AVL, as we sort of talked about. You can also see why leads V5 and V6 might show some changes, as they also sit in that area on your ECG. Okay guys, how about you have a peek at this one? So I think again, looking in terms of STEMI, you're going to be looking at 2, 3, and AVF with the ST elevation. And you might even convince yourself that lead V6 has a bit there, sort of suggesting that maybe there's a little bit of ischemia over on the lateral aspect. But this is pretty much an inferior MI. And again, if you have a peek at this, the inferior MI and the inferior aspect of the heart, of course, covered by leads 2, 3, and AVF down on that sort of lower end of the heart there. Yeah. So again, have a moment and take a peek at this one. So the obvious things that jump out at you, ST elevation in leads 2, 3, and AVF, making you think that you've got yourself an inferior infarct, which is very true. But the anterior septal leads, V1, V2, certainly are elevated also, making you a little worried that you've got right ventricular infarct and RV involvement here. So certainly this might happen with sort of basically a large RV infarct going along with your inferior infarct. And I think many of you have run across this, but if you haven't, when we're worried about either posterior extension of an infarct or involvement of the right ventricle, we do what's called a 15 lead. And for a 15 lead, we essentially just take V4 and move it onto the right side of the chest, so V4R, and then we continue the electrodes around the left chest, which becomes basically V6, V7, V8, and V9. And we're particularly interested in V8 and V9 just to give us a really look at the posterior aspect of the heart. So this is that case you had just looked at here with V4R on it. So this time we're looking at the right ventricle. And again, you can see 2, 3 AVF definitely got ST elevation. And when you look at V4R, there's definitely ST elevation there, which means you have an inferior infarct with right ventricular involvement. That, of course, is worrisome for two reasons. Number one, it's just suggestive of a much larger infarct territory. And number two, patients with right ventricular involvement, of course, are going to be very sensitive to their fluid status because if the right ventricle is not pumping very well, you can't get the fluid out to the left ventricle, which gives you systemic hypotension. So I think most of us have run across this, but the patient with the big inferior, and particularly if they've got RV involvement and suddenly get hypotense, these are the ones who need fluid therapy, pump up their right heart sides, get some fluid over so it crosses over to the left and gives them some ability to pump some volume out to the body. So just be a little wary. These are the patients who get into hypotensive trouble with your nitro, and but will be very fluid responsive. And so again, if you just have a peek at this, this makes total sense. So 2-3 AVF, that's your inferior, and then V4R pointed over just to your right ventricle there, give you a bit better look at the RV. All right, if I told you this was a 64-year-old patient with chest pain, why don't you have a look at this ECG and take a moment to think about what this is. Right, so I think what probably catches your eye right off the bat is the ST depression, sort of a bit in V1, certainly markedly in V2, V3, a little bit in V4. And you may make an argument there's a bit of ST elevation in V6, which will make sense in a second here. But when you see ST depression that's particularly localized in those really anterior septal leads, so V1, V2, and V3, you might say, okay, this is just ST depression in the anterior septal leads, except remember what I told you about ST depression is it actually doesn't localize. So isolated ST depression in these leads right on sort of the anterior septal part of the heart are quite possibly a reflection of a posterior infarct, so infarction on the back part of the heart, and we're just seeing the reciprocal changes here basically being sort of V1, V2, and V3. So in this case, we went ahead and did those posterior leads at V7, V8, and V9. And lo and behold, look at that, you have ST elevation in those leads. So this is actually a posterior infarct. It's not ST depression in your anterior leads, but rather a posterior infarct. And so if you have a peek at that, you can see sort of that plane of where V1, 2 sit, and they are just the anterior part of where 7, 8, and 9 would be. So if you continue to follow those V leads around, so 1, 2, V4, V5, V6, V7 would be behind it, and then 8, 9 would be right behind the heart, and that's where you would place those. So that is actually a quick summary and probably just a review for most of you. Just a reminder, the ECG changes we look for with acute ischemia, hyperacute T waves, and sometimes T wave inversions, although a little less frequently acutely. ST depression, of course, which is going to be non-localizing, and then ST elevation which is the big STEMI we're going to be worried about. And then really by looking at the leads you see the ST elevation changes in, we can make a pretty good guess as to the location of the ischemic event, the anterior septal being in the V1, V2 distribution, anterior apical being V3-4, anterior lateral 1 AVL and V5 and 6, your inferior leads being 2-3 AVF. The right ventricular we sometimes see in V1, and then we're going to do that special lead, that V4R, to look at. And then posteriorly, remember, we're going to look for changes in V1, V2, and V3, but really it's the posterior leads, V7, 8, and 9, that are going to help us have a really good look. And with that, we are finished with our quick review of acute ischemic changes on the ECG.